Thank you, and thank you for the opportunity to speak. And I think any talk about PAD in these days is getting more and more interest into the antithrombotic or medical space. These are my disclosures. I really have two messages. I'm going to talk a little bit. This isn't new to this audience. I'll just spend 2 slides on sort of undertreatment. When I say undertreatment, I'm actually going to talk about the medical undertreatment and a little bit about revascularization. And then I'm going to think about antithrombotics and PAD and tell you about the misconceptions that we've been thinking about as cardiologists that may or may not explain some of the things we know about PAD. So let me get started. First, this is a manuscript from Denmark, which showed something that I think exists here. Now, why was it in Denmark? Because they actually know the prescription rate of aspirin in Denmark, because everybody's on the same sort of formulary, if you will. If you had coronary artery disease, then your chance of getting an aspirin or an antiplatelet agent was 1. If you have PAD, this is now 2010, 2012, you had a 40% chance of getting an antiplatelet therapy. You had a 50% chance roughly of getting a statin, and a 40% chance of getting it. If you had PAD plus CAD, it was higher, but not all the way back to CAD. Even if you had CAD with PAD, it was less than CAD. So something to think about. What about when you use dual antiplatelet therapy? This is from Medicare Part D. This was published recently in the American Heart Journal. 86,000 patients roughly who undergo revascularization. 25% of these patients were on dual antiplatelet therapy for greater than 30 days. So the majority of patients were not getting dual antiplatelet therapy for greater than 30 days. We can talk about what the right answer is. We may not know that yet. But what's interesting is 20% of patients were not on any P2Y12 after revascularization. And then this is the final one we use often. Sri Vemlupalli presented this from Medicare. And this is from 10 years, from 2000 to 2010. Up to 30% of patients didn't get any sort of arterial testing prior to an amputation in the United States. So it just tells you about the unmet need that we're all going to be working on against other things. So let's talk about the antithrombotics. The first misconception. One stronger antiplatelet agent is better than a weaker one for PAD. Well, that means that should make sense, I think. If you look at this review we wrote, when you think about the platelet, for many years, our strategy has been to increase the antiplatelet therapy for patients with coronary disease. Remember, it started with aspirin, then we added aspirin plus clopidogrel, then we had aspirin plus prasugrel or ticagrelor in patients with acute coronary syndromes, and that led to eventually chronic therapies and then dual antiplatelet therapies. So what's the evidence in PAD? Many of you know this. This is now 20 years old. The Capri trial evaluated aspirin plus clopidogrel, and a little stronger clopidogrel was better. It's about 8.7% better, and then it is better when you think about the PAD patients. It was better, but not impressively better, but it was better. I participated in the Euclid trial with many people. This was a 14,000 patient trial where ticagrelor was compared to clopidogrel in 14,000 patients with PAD, and they were patients who had an ABI or they had had prior revascularization greater than 30 days ago. And the findings of this trial, which was published in 2016, showed there was no difference between monotherapy with ticagrelor versus clopidogrel for the composite of CV death, MI, or stroke, or for CV death or MI, or even when we included acute limb ischemia or revascularization. So my first sort of conclusion on monotherapy with PAD would be aspirin versus placebo. I didn't show you these data. It is mildly better than placebo, although the trend crosses 1. Clopidogrel is slightly better than aspirin. That's the Capri trial. Clopidogrel is similar to ticagrelor. So at least in chronic outpatient PAD, a stronger antiplatelet agent wasn't clearly better. What's misconception number 2? 2 antiplatelet agents are better than 1. Now in coronary disease, we often think about that. Well, what is the data in PAD? There's really one big trial, the Charisma trial, that looked at clopidogrel plus aspirin versus placebo plus aspirin, and now 20,000 patients published years ago again, and showed that there was a small difference, 0.5%, that was not numerically different statistically, and there was more bleeding with clopidogrel plus aspirin. So we do use it after revascularization because our patients have received a stent, but the long-term data for that therapy is also not there. So what's the new learning, if you will? I think the newest learning is that for patients with peripheral artery disease, because remember it's a vascular atherosclerotic burden, that dual pathway therapy agents, or agents that are doing more than just antiplatelet work. The first agent that was studied in this regard was Voyager, where there's certainly antiplatelet work and tissue factor effect and possibly into the factor 10As. Voyager we'll talk about first, and then we'll talk about rivaroxaban that's being studied as a factor 10A inhibitor with aspirin in PAD. So Voyager was added on top of aspirin or clopidogrel in patients after an acute coronary syndrome, and this subgroup of those patients who had PAD by Dr. Banaka showed that In fact, they did have less rates of hospitalization or acute limb ischemia, less urgent revascularization. And even if you looked at their peripheral vascular revascularization rates, after a couple of years, they started to diverge so that there was some chronic effect. But this therapy was on top of aspirin or clopidogrel and patients were bleeding, and it was hard to get adopted. So this is the rivaroxaban data, the COMPASS trial you have likely heard about, 2.5 milligrams of rivaroxaban plus aspirin compared to aspirin. There was a 5 milligram arm. This trial was stopped early, 22,000 patients, was stopped early for a mortality benefit. So patients with coronary disease and PAD got into the trial. Here's the PAD cohort. You can see that the patients with PAD had a rate of death, myocardial infarction or stroke of 5.1%. It was higher statistically with aspirin alone, and likely, and there was trends in all three of the groups. There is a price to pay. There is an increase in bleeding, but there was no change in fatal bleeding or ICH, and this is the 2.5 milligrams twice a day dose of rivaroxaban. The PAD subgroup of COMPASS showed reduced acute limb ischemia, major amputation, all vascular amputations, and all major adverse limb events. So it becomes complicated, even though these events aren't very numerically high, it does look like when you add them all up or individually, they're statistically less in this fairly large study. So what are my conclusions to start us off on antithrombotic therapy and PAD? How would I think about it today, and how would I think about it over the next year? It's common, we have to do better for that. I don't think many people would disagree with that. The best current therapy for PAD in chronic care, I would say, is monotherapy, ideally with generic clopidogrel. It's the one that has the most data. Post-revascularization, the majority of patients are being treated for less than 3 months, although we know for the DCB and some of the other device trials, they got 6 months of therapy. So if you use those therapies, you might use longer. Dual pathway inhibition rather than DAPT with rivaroxaban plus aspirin reduced MACE, MALE, and amputation. As this goes through the FDA, I suspect a fair bit of our patients with PAD will likely be at least candidates for this. And finally, there's a trial called Voyager Pd for patients post-revascularization or post-peripheral intervention. 6,500 patients already enrolled with aspirin compared to aspirin plus rivaroxaban. They were allowed to have DAPT post-revascularization for up to 3 months or even up to 6 months. This will be completed in 2019 and will likely inform us even more how to use these therapies for our patients with PAD. Thank you.